So I'm not talking about anything measuring ultrasound. I'm talking about a bigger issue here. And let me just ask how many people in the room are aware of David Barker's fetal growth hypothesis. Okay, so that's really what this is about, just to try and get everybody on the right track. So the idea that what happens in pregnancy might have long-term consequences is, of course, in the popular culture. This from a Time magazine cover not long ago, but it is not a new idea. The notion that what happens to the mother during the pregnancy might have long-term effects on the fetus has been around a long time, and I'll start with the book of Genesis. So you remember Jacob had this kind of fraught relationship with his father-in-law, Laban. And he kept trying to get away, and Laban kept thinking of more tasks for him to make Laban rich. And so one of the last challenges that Jacob was faced with was the tale of the mottled sheep. And the deal goes like this. Laban said, you can leave with my daughters and go off and make your home someplace else, but I'd like you to do one more thing for me, and that's to care for my flocks for another decade or so. I forget what it was. And Jacob said, okay, I'll do it, but here's the condition. I want to be able to keep all of the sheep that are produced by those flocks that are mottled, that are spotted, that have multicolors. And I'll even let you give me a flock of sheep in which you've taken out all of the mottled animals. Give me sheep and goats that are all solid color. Let me take care of them. And then all the mottled ones I'll keep. And Laban thought that sounded like a pretty good deal, so that was, they shook on it, and that was that. So Jacob, of course, is a clever guy. So he had this idea that he would produce mottled sheep by taking branches of a tree and whittling on them to expose the white wood underneath and making them mottled, and setting these branches in front of the water trough where the sheep and the goats would come to drink, and this also was where the animals would mate. And so he had this idea that if he exposed the sheep to these mottled sort of visual images at the time that they were conceiving, that it would produce mottled sheep and goats, and of course it did. And you know, Jacob also did it with only the strongest animals, and so he ended up only increasing his own wealth. So that's one story. Another comes from, you know, about 1,000 years later from the much more, you know, supposedly enlightened Greeks, and they advised women, in fact it was a law, that pregnant women should go look on these statues of the own children would be well-formed and strong. So these are ideas that have been in human culture for a long time. It's been brought to the fore in modern times by David Barker, who just died a few months ago, and something called the fetal nutrition hypothesis. He published this first in the BMJ in late 80s, and then published hundreds of papers afterwards. It launched quite an industry in research, and these are David's own words, kind of summarizing the core of his hypothesis. And it was that cardiovascular disease originates through the responses of a fetus or an infant to undernutrition that permanently change the structure and the function of the infant's body. So I'm just going to emphasize a couple of points here. One is his interest is in cardiovascular disease, and this extended to somewhat to diabetes also, through undernutrition. And his idea of what undernutrition might be evolved over time. At first it was strictly birth weight, and I'll show you some data showing that low birth weight is associated with higher cardiovascular disease. And then his hypotheses got more subtle, and it wasn't just birth weight, it wasn't just mother's nutrition that produced birth weight, it was other things that were going on with the placenta and other things. But cardiovascular disease and some aspects of maternal nutrition that were putting the baby at risk of cardiovascular disease. So this has spawned, as I say, a small industry. If you do a PubMed search on birth weight and cardiovascular disease, there are more than 6,000 papers. In fact, this whole area of research has led to some interesting biological observations about embryonic development and about the transmission of disease risk, including a fair amount on epigenetics. Epigenetics has been embraced by the Barker people who study these things. But it also has led to this recommendation that better nutrition of the mother and therefore better fetal growth during pregnancy can reduce cardiovascular risk. So now we're taking an observation about birth weight and heart disease and converting it into public health policy. And at that point, things get much murkier. So let me just be totally upfront here and tell you that what I'm trying to do here is to create an immense amount of dissatisfaction in you with Barker's hypothesis. And I'm going to do it not by trying to persuade you, but by presenting you with information. And so you can tell me at the end how successful I've been. So let's go to the original kind of observation that was Barker's inspiration. These are data on cardiovascular mortality. These are from a more recent paper from Denmark, where they linked the birth weight of the infants to mortality. And this pattern that you see here, with lowest birth weight having the highest disease risk of cardiovascular mortality, is exactly what Barker originally saw that stimulated his hypothesis. Now there is this little upturn here that's kind of annoying, and Barker ignored that. And in fact, we don't know what it is. I point it out because you're going to see it again. So it was based on this association that Barker launched his hypothesis about poor nutrition and cardiovascular disease. Now there are a couple of issues here. One is the amount of risk here is pretty small, 1.2 hazard ratio. So we're not talking about huge effects. Also, we don't have any information about fetal nutrition, and to suppose that smaller babies are not getting as good nutrition as larger babies is really a hypothesis in itself. But all we really know is there's this association with birth weight. So one of the most interesting things about birth weight when we consider adult health is that birth weight is associated with lots of things. And not always in the direction that that first slide suggests. So it's very well established that cancer mortality is related to birth weight. It's not all cancers. It's, breast cancer is a strong one. Childhood cancers is another. But in the same study that did that that Danish study that had the birth weight and cardiovascular disease mortality, they also look at cancer mortality. This is what it looks like. The bigger you are at birth, the higher your risk of cancer, of dying of cancer. Okay? Now, there's a third category that we can look at, which is all the mortality that's not cardiovascular disease and it's not cancer. And what does that look like? Well, it looks a lot like the cardiovascular disease pattern, actually. Same level of risk, same kind of linear relationship here, and a little turn up at the end. So now let's go beyond mortality and talk about various kinds of morbidity. Now, the interesting thing here is that nobody has ever systematically looked at birth weight and lifetime morbidity or diseases. The data I'm going to show you are just things that have randomly popped up in the literature. But they're based on large numbers, and I think that they're, just on a statistical basis, they're solid observations. The reason for them is something else. So let's look at hearing impairment. This is looking at Danish military recruits universal military service in Denmark. They can link the birth weights of these recruits to their tests when they're going into the military. Here's what we see. The risk is actually higher than 1.2 here. And, oh, look at this little turn up at the end. That's interesting. Mental handicap. Schizophrenia. He's from the Swedish military. This is one of my favorites. Record of having your kid seen in the hospital because he broke a leg or had some other injury. So lower birth weight is associated with lots of interesting things. And all of this without even, being systematic about it. I suppose you're going to want me to tell you the answer to why this is true. I don't have any idea. But it does, if we go back to Barker, we have to ask some questions. If fetal nutrition is the source for all of these poor outcomes, then we've got to widen our scope here. Only looking at cardiovascular disease is way too narrow. We need to think about things more broadly. Or does this broad swath of associations suggest that there's something else going on that's not causal, that there's some other confounding going on? What might that confounding be? Well, in fact, there's been a fair amount of skeptical work done on Barker's hypothesis with cardiovascular disease, looking at the possibility of confounding. And one of the most persuasive, from my standpoint, has to do with this graph that I'm going to show you, or this directed acyclic graph, I guess you'd call it, where the observation is that if the baby has low birth weight, as an adult, it's going to have increased heart disease. But some British researchers did a very clever analysis where they looked at the mother's risk of heart disease. And they found that if the mother went on to have high risk of heart disease, she was more likely to have small babies. Well, isn't that interesting? Because clearly mothers at high risk of heart disease are going to have children who have high risk of heart disease. So what is this about? What is it with mothers at high risk of heart disease having smaller babies? Is it their diet? Is it genetics? In fact, there are some genetic studies suggesting that variants that are associated with high cardiovascular disease risk are also associated with smaller birth weight. So what could explain all those other associations that I showed you? Nothing in the maternal nutrition hypothesis addresses those things. Maybe there are other types of confounding. Nobody is asking that question. Nobody is asking, why is birth weight associated with deafness? Why is it associated with kids climbing trees? Joe?
But that one paper looked at all that, so they must have thought of something.
It was kind of a phenomenon.
It's like, oh, this is interesting.
No, right, right. There is no body of theory. There's hardly any reckless speculation on what this is about. So, in your spare time, if you want to work on an interesting question, it seems to me this is something that deserves a little thought. But I'm going to leave all that. I'm going to just hope that I've at least undermined your confidence in the Barker hypothesis a little bit. And I'm going to instead point you in a direction that I think is a lot more interesting than Barker's hypothesis. And I'm going to get into this. Well, first I'll offer some conclusions that I think we all can agree on. I would never argue against good nutrition for mothers. I mean, that's sometimes when I'm skeptical about this, people will say, well, don't you think we need to do a better job of feeding mothers? Hey, yes, absolutely. But there's no evidence that making babies heavier reduces their risk of cardiovascular disease. In fact, there's not much better evidence that giving mothers better nutrition changes their baby's birth weight. So have 6,000 papers asked the wrong question? And if that's the case, what's the right question? So this is what I would like to do, is talk about the right question. And I'm going to start all this by telling you a story. Okay? And it's going to be a little thought experiment, so I'm going to need you to work with me here. Imagine an exposure that we'll call X that causes reproductive problems. Exposures to a woman. We'll say that X increases infertility 2 to 4-fold. We'll say that it increases the risk of miscarriage up to 2-fold. We'll say that it increases tubal pregnancy, and it increases preterm delivery 2 to 3-fold. Okay? So now imagine that we expose 2 million women to this, whatever it is. This ought to be easy to detect, right? Because the effect is strong. We're not talking about odds ratios of 1.2 here. We're talking 2, 3, 4, 5, 8. So big effects. The outcomes are common. These are not rare diseases. These are something everybody can look in their clinics. So, you know, this is all the ingredients of the kind of studies that we can actually do in epidemiology. And a large number of women were exposed. It's not a rare exposure. So, seems like it's just, you know, this should be a piece of cake for epidemiologists. This really happened. And the amazing thing is, we almost didn't notice it. So the question is, what is X and why didn't we notice it? The reason we didn't almost notice it is because X occurred before the women were even born. So those of you who are too young to remember this episode might actually be surprised at what I'm going to show you here, and others of you know exactly what I'm talking about. X is diethylstilbestrol, or DES. So DES is an amazing story in itself. I mean, it's really remarkable. It was synthesized in a laboratory, in a government laboratory in Britain, end of the 30s. It's very easy to make. And it works orally. So it was one of the first estrogens you could actually give to people in a pill form. Well, this was very exciting, and before we had strict rules about establishing whether a drug did any good, there was a lot of quite imaginative use of this drug to try and find a clinical purpose. It was prescribed for venereal diseases. It was given for all kinds of purposes, and kind of in parallel, there were two very important researchers at Harvard who did animal studies, and they formed the hypothesis that one of the causes of miscarriage in humans was kind of insufficient hormonal support. And so the way that you could improve a woman's success in carrying her pregnancy would be to supplement her hormones a little bit. And DES seemed like a great possibility for that. They did some clinical studies where they took women who had had 2 or 3 previous miscarriages and gave them DES, and lo and behold, 75% of these women went on to have a successful pregnancy. No control group. So it was proposed as a drug to improve the outcome of pregnancy in high-risk women. It was in the late 40s. It was approved by the FDA for the use in pregnant women. And in 1953, a randomized double-blind clinical trial was done that found no benefit of DES. This is one of the first randomized double-blind studies ever done. University of Chicago. Same hospital where they had that plaque waiting for the preeclampsia discoverer. So you might think that would slow down the prescribing of DES, but 3 years later, in the same journal that published this negative clinical trial, there was this advertisement. Yes, DES to prevent abortion, miscarriage, and premature labor. Recommended for all pregnancies. Women were told this is something like a vitamin. Prove your pregnancy. Bigger and stronger babies too. None of this established by the clinical trial, but there it was. So DES was prescribed in some places in the United States through the 1950s, through the 1960s. And then, but little used in Europe, interestingly. It's one of those things that had strong advocates in the U.S., but not elsewhere. And we don't have a really good estimate, but people have tried to calculate by the production of this drug in various companies. By the way, the drug was never patented because it was produced in a government lab. So anybody could produce it. It was produced by dozens and dozens of pharmaceutical houses. And about 4 million women were exposed in the U.S. So, turns out DES had a consequence that was quite serious. In the late 1960s, 7 young women were diagnosed with vaginal cancer at Massachusetts General Hospital. There was a young resident at that hospital named Arthur Herbst, who went on to become the chief of obstetrics in University of Chicago, that same lying-in hospital. And Arthur had done a case report on a young woman who had vaginal cancer. This is very rare in any women, but up to that time it had only been reported in women who were quite elderly. So seeing it in young women was unusual. These were women in their late teens. And within a few years, they had accumulated 7 cases. It was clear something was going on. I worked with Arthur in another project, and so I had a chance to hear him talk about this whole experience of identifying these young women and trying to figure out what the exposure was. And it was one of the mothers of the young girls who asked the doctors if it was possible that the drug that she had taken in pregnancy might have caused this disease. And so the Herbst and his colleagues did a survey of these mothers. I think there were, I can't remember, I think there were 8 cases and like 24 controls published in the New England Journal, just to show you that case control studies don't have to be huge. And all but one of the mothers reported that she had taken DES in pregnancy, and only one of the controls. So that paper was published in 1971. The FDA immediately withdrew its approval of DES for use in pregnant women, and the rest is history. Then we discovered that DES not only caused cancer, but all of these other problems with infertility in the exposed women and increased risk of preterm delivery, et cetera. So there were a total of about 500 cases of vaginal cancer reported in the United States. But the other effects of DES on women were much more widespread than what we usually think of as the outcome. So extrapolating from the data that we had from actually the randomized clinical trial was followed up and had a source of very important information about the subsequent risk to the daughters and the sons. In the U.S., we estimate about 100,000 women were made sterile, about 300,000 excess preterm births, neonatal deaths, cerebral palsy, mental retardation. So, here's the question. What if DES had not caused vaginal cancer? Would we have noticed that about 5% of the women in the United States had lower fertility and increased risk of preterm delivery? If we had noticed it, would we ever have thought to ask them about what their exposures were 20 or 30 years later? And if we had asked, would these women have been able to tell us? So let's talk about the fetal origins of adult disease. I'm much less concerned about some aspects of maternal nutrition that we can't measure, and I'm much more concerned about things that women might be exposed to in their pregnancy. It is a hypothesis that fetal nutrition might affect cardiovascular disease. It is not a hypothesis that toxic exposures during pregnancy can cause serious adult illness. So I'm going to take a little side tour here. I just can't resist doing this. That randomized clinical trial that was published in 1953, it was reported as negative, as null, no benefit. You should go back and look at that paper, because what in fact it shows in the tables is that the treated group had a higher risk of low birth weight, a higher risk of preterm delivery, a higher risk of neonatal mortality. Statistically significant. The authors never reported that. They never discussed it in the paper. And I suspect the reason is that the medical community was already outraged that somebody would publish a clinical trial showing no benefit, and that if they had commented on the fact that it was actually harmful, that they would have had no credibility at all. So, toxic exposures during pregnancy. Where do we even begin to look? Well, one thing we can do is to try and glean some clues about what we already know about prenatal exposures and adult disease. Now, these data are of varying degrees of quality, but I'm just pulling it all together to try and get some clues. So there have been some studies looking at maternal smoking during pregnancy, and once again, I think this is looking under the lamppost. It's we know smoking isn't good for you, but it's also an exposure that we can actually collect reasonable data on. It's very hard to know what a mother's nutrition was during her pregnancy, or what kind of drugs she was using even. It's much easier to figure out if she smoked, because you can ask her and she'll usually tell the truth. So there are studies reporting decreased sperm quality among mothers who were smoking high levels during pregnancy, decreased male fertility, and decreased female fertility. These all need to be confirmed in larger studies, but not biologically implausible. The germ cells are all present in the fetus, and there's no reason why they couldn't be in some ways affected by the mother's smoking. Let's talk about infection during pregnancy. This is pretty interesting. So you all know about the flu epidemic of 1918. So there were some economists, not epidemiologists, there were economists who did a very interesting ecologic study where they traced the civil records on Social Security and education for people, and looking at their birth dates and looking at people who had their pregnancies just before this epidemic, who were in utero at the time of the epidemic, and who entirely had their pregnancies after the epidemic. And this epidemic was concentrated in quite a short time. It was during the just over a course of 3 or 4 months. So it's a very well-defined exposure. And these economists looked at the economic performance of the cohorts of people in the United States who had their births around this time and might have been exposed to in utero influenza infection by their mothers. And what they found was that the level of adult disability and lower educational achievement was higher if the pregnancy occurred during the flu epidemic, or the other way around, the flu epidemic occurred during the pregnancy. So this is entirely ecologic, but it does suggest that in the presence of a severe infection, there may be damage to the fetus. And of course, the 1918 epidemic, as you probably know, was quite severe in young people. It was, that was the group that had one of the highest levels of mortality. So infection might be another exposure during pregnancy that can have long-term consequences. And in that spirit, there is a study showing that mothers who have influenza in their first trimester are at greater risk of their children having schizophrenia as adults. So now we're looking at neurologic outcomes in relation to infection. So how does this all add up? Some exposures that we might suspect are prescribed drugs. Always a worry to physicians who, first of all, want to do no harm. Self-administered drugs like tobacco, and infections. All of those things are things we might be worried about, but certainly not limited to this list. How about the diseases that we might focus on? Cancers, for sure. We know that DES caused vaginal cancer. Reproductive problems, also very prevalent in the DES daughters. And neurodevelopmental problems, as we've seen from the infectious disease exposures. So let's talk a little bit more about cancer. The emergence of DES as a producer of this terrible cancer in young women led to a flood of animal research on transplacental carcinogens. This became an area of research in itself. And in animal models, experimentalists were able to show many types of cancer associated with maternal exposure to carcinogens. In fact, such a broad spectrum that we might worry about any kind of a cancer having prenatal origins. So, have we found any other prenatal exposure besides DES that causes cancer in humans? We have not. That's, maybe a good thing. But DES may cause more than one type of cancer. This cohort of people age is that the risk of breast cancer seems to be higher in DES exposed than the unexposed. There's also some concern about prostate cancer in the sons who are exposed to DES. Any cancer that has an increasing incidence in the population, it seems like, is a candidate for considering the possibility of prenatal exposures. So childhood cancers, a number of them are increasing in their risk. And childhood cancers, it seems to me, is an especially good candidate because the origins of that cancer, considering latency, is very plausibly includes the prenatal period. Testicular cancer is another type of cancer that's increased. There's been a fair amount of work looking for prenatal exposures, and none's been identified so far. Non-Hodgkin's lymphoma, also largely a cancer of young adults. So all of these plausibly have fetal origins, and we should be taking that into account. So if the animal experimentalists have any advice for us, and I think we always have to take mouse models with a grain of salt because things don't always pan out in humans, but there is a finding that I think is disturbing that we need to keep in our minds. And this is a study that was done in which they exposed the mother to DES during her pregnancy and then looked at her offspring, looked at the cancer in the second generation, and they found increased risk. And just because they had these pups, for no particular reason, not because they had a hypothesis, they just bred those two to see what would happen. They also had increased cancer risk. This was such an unexpected finding for the in utero exposure to have third generation effects that they didn't even publish the data right away. It happens that these are folks at my own institute. Retha has an office just around the corner from mine. And so I remember talking about this with Retha in the hall, and she said, you won't believe what we found with this third generation. She said, we can't publish this. We don't have any mechanism. We don't understand how this could happen. So they did the whole thing again, and by the time a little more time had gone by, this was published in 2006, there was enough emerging about epigenetic changes with hormonal exposures that they could actually make a biologically plausible argument here for a third generation effect. Whether this is true in humans, we don't know. Where can we find data? This is not the sort of study you can easily get a grant to fund because it requires often data over a long period of time. But we can try and take advantage of data that exist. Birth cohort studies in the United States was done in the early 1960s, and it's still very useful for studying prenatal exposures. There's been no, and it's been used to try and study effects like of prenatal pesticides and other things on adult disease, and not much has turned up there, but that's the place where we might actually hope to find it. Linked medical records are another place. You know, now that there's such a big push to have electronic records computerized and accessible to researchers, we can actually think about doing this sort of thing in the United States. Just as a postscript, you know that part of the stimulus package that the government put through in rescuing the economy a few years ago, there was a lot of money that went towards computerizing medical records. But none of that money was targeted at exposures during pregnancy with an eye to looking at outcomes in the kids. And you know, it seems like that's still a great opportunity that needs to be taken advantage of. Just a word about large birth cohorts. This is where you enroll women in pregnancy and collect biological samples as well as information from them about their exposures and have long-term follow-up. You all are, I'm sure, aware of the child health study that's trying to get its feet under it in the United States. There have been large birth cohorts in Denmark and Norway and smaller ones in Europe. In fact, it's that Norway cohort that gave me some of the data that I showed you in the first talk. And whether we're actually going to get a U.S. child health study remains to be seen. But what I think we ought to do is have a new cohort study every decade. I mean, you trade in one aircraft carrier and that'll pay for 2 or 3 cohorts. So, you know, the only way we're going to find this is if we're really looking for it. The use of medical records, it would be great to be able to link prescriptions and medical procedures in pregnancy with long-term follow-up of the offspring. This is possible in our colleagues in other countries, but the important thing is we have to think to even ask the question. Even if the data are out there someplace. And, you know, most of these people are willing to collaborate with outsiders. If you had a great idea, you could contact these people and see if you could do a study within these cohorts, but you have to ask the question. And that's, I think, where one thing that we can change. So, in summary, the emphasis on fetal nutrition that Barker kicked off has produced some interesting science. I won't deny that, but I think as a public health intervention, it's really put the emphasis in the wrong place. I'm much more worried about damage to the fetus that might come through either environmental exposures or even, God forbid, exposures that we ourselves give to pregnant women in our medical care. This damage can be major, no question about it, and it can be hard to detect. But we won't find it unless we look, and that's the message I want to leave you with. Glad to discuss any questions.
So how generalizable do you think Scandinavian results are in the U.S. population?
How generalizable are the data in Scandinavia to the U.S.? It's a yes and no thing. They're human beings. If we think human biology is the same around the world, then to that degree we can learn something. It's obviously a different social context. It's not as diverse a culture, not as diverse in its range of ethnic groups, although they're getting more diverse all the time. So I think it depends a little bit about what the particular observation is you want to extrapolate.
Also, are you aware of the Fetal population database? It's a local database where we track, Fetal is a track, health outcomes, deaths, certificates, et cetera, for over 50 years, and almost everyone in the top.
In linking the families?
Linking the family.
Right. Yeah, you guys almost scooped one of my papers. I'm aware of you. Yeah. Not you? Okay. No, it's a great resource, right? And I didn't mention that here, and I should have thought of that. I think that's actually how deep you could go in that kind of data linkage for the kind of questions I'm raising here. I don't know, but that's a wonderful resource. Yes.
I have a two-part question. One is about how we try to get maybe the public thinking about this. I like the point that the suggestion about DES came from the patient's mother. So, I mean, as a parent of two young kids who are like 1 and 4, I feel like they seem normal, they're on track, I'm out of the woods, right? And I think that's what people tend to think without, thinking about, the
I have a hypothesis, but it's so far out that I'm just going to leave you shaking your head at how you ever let this guy come into your room. I'm just going to present this as a hypothesis, and I'm sure there's other things that it could be, but this is the one I'm pursuing. So I'm really interested in the fact that birth weight is so strongly associated with perinatal mortality. Dissertation. And the graphs, if you were to look at neonatal mortality by birth weight and only look at term babies, so you kind of get preterm out of the picture, the risk of mortality with low birth weight is 100 times higher than babies at a little above the average birth weight. And then it goes up a little bit for the heaviest babies. And that pattern is present for any particular cause of death you want to look at. It's not that the small babies have one kind of mortality and the large babies have another kind. It is some kind of an underlying vulnerability that we don't understand. So my colleague Olga Basso and I wrote a paper in which we said, what kind of a confounder would have to be present in newborns to create this pattern if birth weight itself had no effect on mortality? And so we quantified that there could be this rare thing that goes wrong in pregnancies. It would affect about 0.5% of all babies. It would have very high mortality in relative terms, like 160 relative risk, but in absolute terms, mortality of maybe 4%. And it would be associated with very small babies. So it's strictly an academic exercise. What would it take? And then you have to hypothesize something else that makes babies big and causes higher mortality. So then we said, okay, if you hypothesize these two unknown confounders, then you can also hypothesize that birth weight itself has no relationship to mortality. And in fact, let's get real. Why should birth weight be related to anything? It's just, just body size. Why should that be a cause of anything? It's just,
Well, it's obviously a marker in any case. Right?
It's a marker for something. And one possibility is the smaller you are, the more likely you are to have this other condition that's causing this high risk. So what could that be? It's present, this pattern is present in every population in the world. If you look at the healthiest Swedes who are in their second pregnancy, who don't smoke, you see the same pattern of mortality with birth weight. I think it's something embedded in biology. It has something to do in the same way that malformations, the birth defects, are embedded in our biology. Birth defects are not preventable, folks. I mean, we cannot make a population of people who have zero birth defects. We can reduce certain kinds of birth defects that are increased by a lack of folic acid or other things, but there's no way we can create a population of human beings that have zero birth defects. Things go wrong in the assembly, the mechanical assembly of a fetus. And I think this is something else that goes wrong, and we don't know what it is. And I think it makes people vulnerable for a lot of things that go wrong in adulthood. I think it affects neurologic things. It's not fatal. It could affect some people in this room. But I think there's something, at least that's my entertaining hypothesis that I'm working on.
Global biological
Right.
assembly.
Right. Are you still speaking?
Yeah.
Okay, good.
Not as radical as I thought we were.
Okay. I don't think, and what I really am trying to do is come up with more data to show that. So one of the things we're doing, Christy, I'll get to your question. One of the things we're doing in Norway is looking at term birth weights, and looking at the risk of every category of clinical problem that we can find in the registries, and actually doing a systematic look like we're doing. Yeah, right. And if it's present everywhere, then that might push me further down my bizarre road of something basic biology. But if it's concentrated in certain causes of disease and not in others, that's a different kind of a clue. So I'm open. Christy?
So I don't really do cancer, but the whole idea about the latent periods,
Mm-hmm.
and I just wonder if we can see all those transplacental carcinogens in animals just partly because the generations are so much closer in time, and the time for humans is so long that environmental exposures can work out anything else.
Oh, that's a great hypothesis. I love
By
that.
the time you're old enough to get breast cancer, you've done plenty of other bad stuff to yourself that might just be washing out that 1.1 increased risk from the DPS.
Yeah, yeah. So I've never heard any biologists talk about latency in mice compared to humans. And I think it's a really interesting hypothesis.
I mean, we just have more time for accumulated environmental insults.
Sure,
over
sure,
time. I mean,
sure.
That graph of the DES and breast cancer,
Mm-hmm.
I wonder if that might go away if you take into account that they're more likely to have infertility, so they may be less likely to have children, or maybe enhanced breastfeeding, and so all the other things that go into breast cancer.
And that's a very good question. And they actually controlled for that stuff in those data. But that's a very good point. No, I think that's I really like that that formulation. That makes sense. Yeah, Lorenzo.
You showed us all of the outcomes that show that J shape
Mm-hmm.
is equivalent
Mm-hmm.
to the birth rate versus outcome hypothesis. So, leaving aside possible publications with biases, but are there any outcomes that have not shown to have that pattern? Is there any information that can be gleaned from that?
The only data I've seen that does not show that upturn are relatively small data sets. And it takes a certain amount of power to see this upturn in this small group of people with extreme high weights. I have never seen a large data set that didn't show it. Well, if there's no more questions, I'm going to be around for most of the rest of the day. And if you something burning question comes up, I'm glad for you to track me down. I'm sure Peggy or Lynn can find me. But I really appreciate the chance to be on the marquee of the SER talks. And I appreciate the opportunity to be with you here and talk about these things. So thank you very much.